Good day, everyone. I will be reporting about Addison's disease. So, let us first start with the definition. Addison's disease occurs when the adrenal cortex is damaged and the adrenal glands don't produce enough of the steroid hormones cortisol and aldosterone. As for the etiology, it is caused by an autoimmune response which occurs when the body's immune system, which protects it from infection, assaults its own organs and tissues. Next, we have here the types. First, we have primary adrenal insufficiency, when your adrenal glands are damaged so severely that they can no longer produce hormones. Another type is secondary adrenal insufficiency, which means when the pituitary gland can no longer produce ACTH. Now we have here the disease process. Addison's disease is a condition that affects your body's adrenal glands. These glands are located on the top of your kidneys. They make hormones that affect your mood, growth, metabolism, tissue function, and how your body responds to stress. We also have here risk assessment. Addison's disease can be prevented, but there are steps you can take to avoid an Addisonian crisis. First, we have talk to your doctor if you always feel tired, weak, or are losing weight. Ask about having an adrenal shortage. We also have, if you have been diagnosed with Addison's disease, ask your doctor about what to do when you're sick. You may need to learn how to increase your dose of corticosteroids. And we also have here, if you become very sick, especially if you're vomiting and you can't take your medication, it is advisable to go to the emergency room as soon as possible. Moving on to the signs and symptoms, we have here muscle weakness, fatigue and tiredness, darkening in skin color, weight loss or decreased appetite, decrease in heart rate or blood pressure, low blood sugar levels, fainting spells, sores in the mouth, cravings for salt, and most importantly, GI distress. Now, as for the diagnostic tests, we have here history and physical. Your doctor will review your symptoms and will perform a physical exam. And we also have blood tests. These will be done to measure the levels of sodium, potassium, cortisol, and ACTH in your blood. Another, we have ACTH stimulation test. This tests the adrenal glands response after you are given a shot of artificial ACTH. And we also have x-rays. These may be done to look for calcium deposits on the adrenal glands. And we also have computed tomography scan. These uses computers to combine many x-rays images into cross-sectional views. This might be done to evaluate the adrenals or pituitary gland. Now moving on to the nursing diagnoses. First, we have risk for deficient fluid volume related to increase in sodium and water excretion. And we also have risk for imbalanced nutrition, less than body requirements related to decreased gastrointestinal GI enzymes, causing loss of appetite and decreased oral intake tolerance. And lastly, we have risk for decreased cardiac output related to the increase in corticosteroids. Now we have the nursing interventions. Assess skin turgor and mucous membranes for signs of dehydration. Assess vital signs. Assess appetite and for presence of nausea, vomiting, or diarrhea. Suggest need for frequent small meals and monitor oxygen saturation levels. As for the pharmacological interventions, we have here administer replacement medication as prescribed or indicated. We have Cortone, Cortef, or Florinef. Now, for the pathophysiology, we have predisposing factors, lifestyle. For the precipitating factors, we have the immune system, mistakenly attacking the gland autoimmune disease, infections such as tuberculosis, HIV, or fungal infections. We also have hemorrhage, tumors, use of blood-thinning drugs. For the etiology, we have adrenal insufficiency, cancer cells in the adrenal glands, autoimmune diseases, and infections of the adrenal glands. For the nursing interventions, we have here assess skin turgor, assess vital signs, assess appetite, suggest need for frequent small meals, and monitor oxygen saturation levels. As for the event, Addison's disease is a condition that affects your body's adrenal glands. These glands are located on top of your kidneys. They make hormones that affect your mood, but Addison's disease damages those glands. As for the signs and symptoms, we have here muscle weakness, fatigue, darkening in skin color, weight loss or decreased appetite, a decrease in heart rate or blood pressure. We also have here low blood sugar, sores in the mouth, and cravings for salt. Now, we have here the pharmacological interventions. Administer replacement medications as prescribed, such as Cortinel, hydrocortisone, Cortef, and Florinef. Now, for the nursing care plan, we have here physiologic deficit, risk for deficient fluid volume. For the objective cues, dry skin, dark urine, bruises, and rapid weight loss. As for the subjective cues, as evidenced by the client, sige ko suka o kalibanga, unya malipong pod ko nga, wala hinungdan. We also have here for the nursing diagnosis, risk for deficient fluid volume related to increase in sodium and water excretion with potassium retention. For the scientific basis, we have fluids and electrolytes are basic components of the human body and essential for the survival of most species. Any imbalance can potentially lead to serious conditions and death. As for the objectives of care, we have here first general objectives. After 8 hours of holistic nursing care, the patient experiences adequate fluid volume and electrolyte balance. For the specific objectives, after 8 hours of holistic nursing care, the patient's urine output will be greater than 30 ml per hour, a non-motensive blood pressure, heart rate less than 100 beats per minute, and consistent weight, as well as normal skin turgor. For the nursing interventions, we have assess vital signs, assess skin turgor, and assess weight. The rationale behind that is that for number 1, a BP drop of more than 15 when changing from supine to sitting position with a concurrent elevation of 15 beats per minute indicates reduced circulating fluids. For number 2, the patient will have dry skin and mucous membranes. Tenting of the skin will occur. The tongue may have longitudinal furrows as well. And we also have here assess electrocardiogram rhythm and assess additional indicated laboratory tests. Now, for the rationale, signs of hyperkalemia are sharp peak T wave and widened QRS complex. And abnormal laboratory findings include hyperkalemia related to aldosterone deficiency and decreased renal perfusion. And then we also have here encourage oral fluids and instruct the patient to ingest salt. Sodium loss increases, extracellular fluid volume decreases. These interventions are necessary to prevent fluid volume deficit because the kidneys are unable to conserve sodium. And sweating increases sodium loss. Then we also have here refer or admit the patient to an acute care setting because immediate hospital admission and treatment are needed because of the high mortality rate with Addisonian crisis. Then we also have here administer parenteral fluids as prescribed because normal saline is infused initially to restore fluid volume. And next we have here is Turner syndrome. Turner syndrome is one of the most common chromosomal abnormalities. More than 95% of adult women with Turner syndrome exhibit short stature and infertility. Turner syndrome is caused by the absence of one set of genes from the short arm of one X chromosome. The diagnosis of a Turner syndrome requires the presence of typical phenotypic features and a complete or partial absence of a second sex chromosome. Maternal chromosomes. In patients with a single X chromosome, the chromosome is of maternal origin in 2/3 of cases. We also have here lack of SHOX gene. Many of the features of Turner syndrome, including the short stature, are due to the lack of a second SHOX gene, which is on the X chromosomes. In patients with 45X karyotype, about 2/3 are missing the paternal X chromosome. In addition to monosomy X, a similar clinical picture is found with a 46 karyotype and in some individuals with mosaic karyotypes. There is no possible assessment that can be done to manage possible onset of disease. Turner syndrome cannot be prevented. It is a genetic problem that is caused by random error that leads to a missing X chromosome in the sperm or egg of a parent. As for the signs and symptoms, we have here lymphedema, like fingers and toes, short stature, dental symptoms, ovarian failure, webbed neck, shield chest, cutis laxia. And for the diagnostic tests, we have here prenatal tests. On fetal ultrasonography, Turner syndrome is suggested by the presence of a nuchal cystic hygroma, horseshoe kidney, left-sided cardiac anomalies, or non-immune fetal hydropes. This may be prenatally diagnosed by amniocentesis. Another is karyotyping. A standard 30-cell karyotype analysis is required for diagnosis of Turner syndrome to exclude mosaicism. And we also have here gonadotropins. Both LH and FSH may be elevated in untreated patients younger than 4 years old. Another is we have here thyroid function tests. Because of the high prevalence of hypothyroidism in Turner syndrome, obtain thyroid function tests at diagnosis. Then we also have here glucose metabolism. Abnormalities of glucose metabolism, including overt diabetes mellitus, are more common than in unaffected children. Screening for diabetes mellitus is best performed by obtaining a hemoglobin or fasting glucose level. Next, renal studies. At diagnosis, perform ultrasonography of the kidneys and renal collecting system. Annual urine cultures and measurement of BUN and creatinine levels are recommended for those patients with abnormalities of the renal collecting system. And cardiovascular studies, perform echocardiography or MRI of the heart and aorta upon diagnosis. And lastly, we have audiology. Infants diagnosed at birth should have a hearing assessment in the nursery. Formal hearing assessment is recommended at age 1 year and before entering school. As for the nursing diagnoses, we have potential for low self-esteem related to body not developing secondary sex characteristics as peers of same age. And we also have here ineffective child eating dynamics related to dental occlusion. And lastly, disturbed body image related to differences in physical characteristics as evidenced by webbed neck, short stature, and shield chest. As for the nursing interventions, we have help patient identify feelings and express them, engage in active listening, help patient explore support system, encourage involvement in medical decisions, and provide the patient with suggestions of physical activities. As for the medical interventions, we have the following: growth hormone therapy, sex hormone replacement therapy, and diet. As for the pharmacological interventions, we have human growth hormone, anabolic steroids, antihypertensive agents, as well as vitamins and minerals. As for the pathophysiology, we have predisposing factors, genetics, precipitating factors, none, and for the etiology, Turner syndrome is caused by the absence of one of set of genes, and for the maternal chromosomes, in patients with a single X chromosome, the chromosome is of maternal origin, and lack of SHOX gene. As for the event, in patients with 45X karyotype, about 2/3 are missing the paternal X chromosome. In addition to monosomy X, a similar clinical picture is found with the 46 karyotype and in some individuals with mosaic karyotypes. For the signs and symptoms, we have here